dear PGs, last two classes we discussed about the dengue fever and enteric fever. Now today malaria is much more dangerous and it is of very severe disease, very big disease in India, and its presentations are very versatile and leads to a lot of the complications like acute kidney injury, cerebral malaria, hepatitis, dick, coagulopathy, and finally the death also. So we should not underestimate the importance of the malaria in our clinical practice. So as a physician, you are supposed to see a lot of the complications of the malaria, and we have to deal these complications with a lot of enthusiasm and your professionalism, so that we can avoid a lot of the mortalities because of the malaria. See, let us spend some time on the basics of the malaria. It's a deadly disease by a tiny bug, that is our mosquito. Okay, so earlier the word malaria was derived from the Italian word mala, means bad, air. So I thought that it was because of the breathing in the bad air in a marshy areas. So this is the culprit. The female mosquitoes, they transmit the malaria. They are the non-vegetarian, like your eats mosquito, that is also non-vegetarian. They feed on the RBCs of the people. So in the same way here, what are all the complications of the malaria? You see it. The creed goes to the infected female Anopheles mosquitoes. So males are comparatively tame and feeding on the plants. So the great man, Ronald Ross, he worked in Hyderabad military hospital. So he discovered the link between the disease and the Anopheles mosquito, and the first made that the differences, the relation between this Anopheles mosquito and the malaria. So he is an army doctor, Scotland army doctor, working in Hyderabad, India. So they thought that it is all vampire diaries. Malaria mosquitoes behave like the vampires. Vampires means they are the villains who comes in the night times, almost like your devils. Okay, so they thought that this disease is more common in the rise at the dusk and embark on a blood-sucking journey until the dawn. So that is how the malaria spreads. You know that these are all the 4 or the 5 types of the plasmodias. Vivax is a very common. Falciparum, it is also so common. Malariae, ovale, these 2 are not that common. And finally the Anopheles, so that is more common in the Malaysia and Indonesia, in the forest areas, transmitted from the monkeys. So these are all the different facts about the malaria. It's a serious disease that is a preventable and the treatable. It's a totally preventable disease, but left untreated, a very big disease, a very serious disease. It is caused by Plasmodium parasites. Humans get infected via the mosquito bites. Pregnant women, very high risk, because the pregnancy and malaria, so a lot of people that die from the complications of the civil malaria with the dick and coagulopathies. A lot of the countries, 97, 100 or 150, what are their ongoing malaria transmission? The lot of the billions of the population are at risk of malaria worldwide, mostly the Africa, Asia. A child dies from the malaria in Africa every 60 seconds, so every 1 minute. So especially the children in Africa, less than the 5 years of age group, there 98% is the Plasmodium falciparum in Africa. Only 0.5 to 1% is the vivax there, whereas in India, nearly 40 to 50% are the vivax or 40 to 50% are the falciparum. See, 10,000 travelers are reported to become ill with malaria after returning the home. I think this is the old slide. Right now, maybe 25 to 30,000 travelers are getting the malaria every. So sometimes it is mild, but most of the times, by the time they present to the physician, it is mostly either the moderate or the severe. It's a medical emergency, so do not ignore the symptoms. Go straight to the doctor. So what are all the symptoms there? The fever, the sweating, nausea, fatigue, rigors, vomitings, diarrhea, jaundice, and finally fatality if left untreated or undiagnosed. So early diagnosis and prompt treatment prevents a lot of the deaths. So this is the very important in malarial diseases. Okay. So what is the ABCD mantra in malaria? A stands for awareness. So be aware of the risk, the incubation period, and the main symptoms. And B stands for the bite prevention. So by using the mosquito nets or insecticides, etc. Chemoprophylaxis, when you want to travel from the one area to the another area which is endemic for the malaria. So there is one should get the chemoprophylaxis, and the diagnosis is very, very important with your peripheral smear examination or the QBC or the rapid diagnostic test or the PCR. So finally the diagnosis is very, very important. Even without the diagnosis, if there is we are in high suspicious to have the malaria, so there is no harm in treating with the anti-malarial drugs, even though your rapid diagnosis test is absent, or your QBC is the negative, or the peripheral smear is the negative. Okay, so this is about the some known facts about the malaria. See, the transmission route, the most common route is the mosquitoes to the humans, and less the common route. Need not be always from the mosquito bite. Sometimes blood transfusion, transplantation, infected needles, and mother to her fetus during the pregnancy. So these two are very, very important. Blood transfusions and the mother to the fetus during the pregnancy. These two are very common when compared to the transplantation and the infected needles. Drinking beer could increase the chances of infection as mosquitoes love the smell of the beer. Why malaria is a deadly disease? Malaria kills more people than the AIDS. Malaria kills more people than the dengue. Malaria kills more people than the other common diseases, what you know that. So don't neglect the malaria. It's a very, very important killer. There is one malarial death every 12 seconds somewhere in the world. So these are all the affected areas in the world. If you see the Indian map, very, very high. Malaria transmission areas is a very high in Indian population. And these people also have the chloroquine resistance. Some people have the pyrimethamine sulfadoxine resistance. And some areas you will have the multi-drug resistance also there. So the chloroquine resistance or primaquine resistance, sulfadoxine resistance, quinine resistance, these are very, very common in South Africa and South America. Okay, so the drug resistant malaria is posing a lot of the problems to the mankind. See again here, the malaria free areas are the green, especially the Europe and the North America and Australia, and eliminating the malaria, and whereas the red shows controlling the malaria. So India, unfortunately, India falls in the controlling malaria since my childhood. Okay, controlling, developing. See, the malaria remains the world's most devastating human parasitic infection. Affects over the 40% of the world's population. Estimates, the WHO estimates that there are about 350 to 500 million cases of the malaria worldwide. In India itself, there are 2 million cases and 1,000 deaths annually. I think this number is underreported. I think much more number of the cases or the deaths annually in the Indian population. See, already I told you all these things. The malaria is transmitted through the bite of an infected female Anopheles mosquito. So all the five, you know that. Falciparum, vivax, ovale, malariae, and Anopheles. You have the two hosts. One is the mosquito, the other one is the human being. And you have the two stages. One is the asexual stage, or the schizogony, occurs in the humans, where the sexual stage or the sporogony occurs in the mosquitoes. So in the humans, we have the exoerythrocytic stage, erythrocytic stage, etc. See, this is the exoerythrocytic stage. See, the number 1 stands for your Anopheles mosquito, probably female Anopheles mosquito. So it's liberating the sporozoites by biting the human being. Deposits the sporozoites. How many? 10 to 15 sporozoites. Roughly 10 to 15 sporozoites injects into the blood, and these sporozoites circulates and reaches the liver. So it infects the liver cells, the sporozoites. So one sporozoite will infect the one hepatocyte. It matures into the tissue zygones. So tissue zygones in the different forms, maybe the early trophozoite, late trophozoites, early zygones or the late zygones, and each takes about the 5.5 to 8 days. So roughly the 6 to 8 days, this sporozoite which enters into the liver will mature like a zygont. Okay, so that is your erythrocytic phase here. So later these zygonts will rupture, will enter into the circulation and reaches to the RBC. So either the stage 1, first one is the female Anopheles infected with the parasite. So bites the host during her routine blood meal, usual in the night time. The parasite at this stage is called the sporozoites. So each bite introduces about 10 to 15 sporozoites into the human circulation. And the third stage, the parasites, the sporozoites, rush to the liver, and each sporozoite occupies a liver cell. So with each bite, so there are about 10 to 15 sporozoites, and these 10 to 15 sporozoites will infect the 10 to 15 hepatocytes. See here, within each occupied hepatocyte, so within the hepatocyte, the parasite develops into the early trophozoites, late trophozoites, early zygont, and late zygont. This development takes about 6 to 8 days. So that is another step. So please follow this. This is very, very important, because to use the drugs at different stages, unless you understand this methodology, so you will not treat the malaria properly. See now the enlarged mature zygont, one hepatocyte, after 6 to 8 days, it ruptures into the ruptures. So it releases how many? 10,000 vivax merozoites and nearly 30,000 merozoites of the falciparum group. So the more merozoites from the falciparum species, 30,000, whereas from the vivax, about the 10,000 merozoites. So these 10,000 from the vivax and 30,000 from the falciparum, from each hepatocyte rupture of with a zygont, this parasite is now called a merozoite. So the merozoites, how many merozoites in vivax? Nearly 10,000 and 30,000 from the falciparum. So if you see the right side, so there is a peculiarity with the vivax. So what is that peculiarity? Relapses, hypnozoites. So these sporozoites, after entering into the hepatocyte liver cells, so some sporozoites, they will sleep in the liver hepatocyte as a hypnozoites. So they take rest in the liver hepatocyte. So how many days? So not days, weeks. So maybe 3 to 52 weeks. You can remember as 3 to 50 weeks. Okay. So this liver or tissue zygonts, then they become the merozoites, and then they enter the erythrocytes and can cause the fever, that is the relapse. So whenever you treat the vivax malaria, so you should stop these relapses also. So if you don't treat the relapse, if you don't treat the hypnozoites of the vivax, so obviously what will happen? After nearly 3 to 50 weeks, again this person will get the fever, again from the merozoites are rupturing into the hepatocytes. So this is how. So while treating the vivax malaria, so not only treating the fever, it's the acute episode, and you should also concentrate on the recurrence and managing the hypnozoites also, so that you can avoid the relapses. See now the merozoites, you know that sporozoites enters into the liver, that is hypnozoite, hepatocyte. So there in about 6 to 8 days, it becomes a zygont, and then it ruptures. It releases the more merozoites, 10,000 from the vivax and 30,000 from the falciparum. Now each merozoite enters the red blood cell RBC. Okay, so one sporozoite is releasing about 10,000 merozoites from the vivax and 30,000 merozoites from the falciparum, and each merozoites will enter into the RBC. See how many RBCs it is attacking. And vivax merozoites prefer to attack the immature red cells, whereas the falciparum attacks the young erythrocytes. Okay, so that is how the falciparum malaria is much more dangerous than the vivax. So see the number of the merozoites it is getting, and now it is also attacking the young erythrocytes, is the falciparum malaria, whereas immature red cells is the vivax malaria. Now step 7. Each enclosed merozoite, it undergoes the development within the erythrocyte. So it enters into the erythrocyte. Now after entering into the erythrocyte, becoming an early ring form. That is a stereo headphone form, a late ring form, a tropozoid, and finally a mature shy joint. So again here it is the blood shy joint. So shy joint formed in the RBC is the blood shy joint. Shy joint formed in the liver is the tissue hepatocyte, okay, or hepatic shy joint. So that is the tissue shy joint. Here it is the blood shy joint. The enlarging shy joint bursts open the erythrocyte. So this process takes around 48 hours, 2 days. Okay. So this is about the changes in the RBCs. So the merozoites enter into the RBC. In the RBC it forms as the ring forms and then the shy joints. This is called as the blood shy joint. And then this enlarging shy joint bursts open the erythrocyte, and this takes about 2 days. So now the ruptured shy joint releases about second generation merozoites. The appearance of the malarial symptoms coincides with the rupture of the shy joints every 48 hours. So the person gets the fever, acute fever, when this tissue, blood shy joint ruptures and releasing the merozoites. Okay, so this is the second merozoites. The first merozoites in the hepatocytes. This is the second merozoites. Now a special feature about your falciparum malaria. So special feature about the vivax malaria, hypnozoites and the relapses. Here this is about the falciparum malaria. So here you will have the sequestration, cytoadherence, rosetting and recrudescence within the 28 days. So I will tell you what you mean by the cytoadherence and the rosetting at a later time. See, this is the cytoadherence. See, attachment of the infected RBCs to the capillary endothelium. So it damages the endothelium. So it causes the vascular lesions. So that is your cytoadherence, falciparum malaria. So the falciparum malaria is much dangerous because of it is attachment of the infected RBCs to the capillary endothelium. And what you mean by rosetting? Rosetting means binding on the infected RBCs to 2 or more uninfected RBCs to form a rose-like structure. So infected RBC surrounded by the uninfected RBC. That is the rosetting formation. And the cytoadherence is adherence to your endothelium, capillary endothelium. So these two are the special features of your falciparum malaria. These two will not be seen with the vivax malaria. See how it happens, the cytoadherence, the RBCs develop sticky knobs on the surface due to the Plasmodium falciparum erythrocyte membrane protein. These knobs squeeze out an adhesive protein which helps in the attachment of the infected RBCs to the capillary endothelium. So this is the rosetting. So finally the recrudescence within the 28 days. So the microcirculation leads to the hypoxia, organ damage, and leads to the various complications of the falciparum malaria. So falciparum malaria will cause acute kidney injury, cerebral malaria, DIC, coagulopathy, ARDS. So these are all because of these cytoadherence and rosetting and sequestration. So now the second generation merozoites, after your rupture of your erythrocytes, now in the large numbers, attack a new set of the erythrocytes. Each merozoite again goes through the usual steps of the development within the erythrocyte, described as in the step 4. So now the merozoites are releasing from the erythrocyte. Again these merozoites will attack the new RBCs. Again the same process will go on. So this is called the erythrocytic cycle, goes on and on. This cycle is also called the schizogamy. So at some point during the cycle, some of the next generation of merozoites become static. That is, they do not develop into the blood shy joints. Instead, these merozoites develop into the male gametes and others into the female gametes. So what will happen after the rupture of the erythrocytes? You are getting the merozoites. These merozoites are also attacking the another RBCs, again forming the merozoites. So some merozoites, they become the static and then they convert into the gametes. So that is the male gametes and the female gametes. Okay. So this is called the gametocytes. Stay in the blood waiting to enter yet another female Anopheles mosquito. So whenever another female Anopheles mosquito bites, so these gametocytes will enter into the saliva of the female Anopheles mosquito. From then, the sexual stage will occur in the mosquito. So here it is the male gametocytes and the female gametocytes entering into the female Anopheles mosquitoes. So once within the mosquito, the male and the female gametocytes start the so-called sexual cycle called the sporogeny. So here the multiplication into sporozoites. Sporozoites on reaching the mosquito salivary glands are now ready to enter yet another host. So this cycle in the mosquito sporogeny is completed in 14 days. So in the male, about 6 to 8 days in the liver and about 2 days in the RBC and another 2 to 3 days in other ways. So mostly about 10 to 14 days in the males and in about 14 days in the female Anopheles mosquitoes to get these gametes, male and female gametes to convert into the sporozoites and ready to enter into the another individuals. So this is the total life cycle of a malarial parasite. So sporozoites enter into the human body, then reaching the liver, and the liver it's become the schizoids, and then the gametocytes, okay, merozoites, and these merozoites will enter into the RBC. So in the RBC again they come the merozoites, and these merozoites attacking to the another RBCs, and some are static, they become in the male and the female gametes, and then these enter into the female Anopheles mosquito, and in the female Anopheles mosquito it again convert into the sporozoites to enter into the other human beings. So the cycle in the males about the 10 to 14, 12 days, and in the female, in the mosquitoes about 10 to 14 days. So this is the sexual cycle. Some merozoites develop into the male and female gametocytes which are ingested by an Anopheles mosquito during a blood meal. In mosquito, they start the sexual cycle and multiply into the sporozoites. These sporozoites on reaching the mosquito salivary glands are ready to enter another host. So this completes in about 14 days. If you see here, the male and the female gametes, they become the zygote, then the ookinete, oocyst, and then the sporozoites. Okay. So from the gametes to the sporozoites, there are the three phases. One is the zygote, then the ookinete, and the oocyst. So same thing here. Same. So cycle in the mosquito and the cycle in the human beings. See, the malaria life cycle is a complex system with both sexual and asexual aspects of all species that infect the humans is basically the same. There is an exogenous sexual cycle phase in the mosquito called sporogeny, during which the parasite multiplies. There is also an endogenous asexual phase that takes place in the humans, that is called schizogeny. So the man is the intermediate host and the mosquito is the definite host. The sporozoites are the infective forms. So this is the pre-erythrocytic cycle. Sporozoites undergo the developmental phase in the liver cell. See, I told you the merozoites number also. So this is the period of the pre-erythrocytic cycle. Vivax takes about 8 days. Falciparum about 6 days. Malaria 13 to 16 days. Ovale 9 days. On maturation, liver cells rupture. They liberate the merozoites into the bloodstream. So the maximum days in the malaria and 6 days in the falciparum, vivax is the 8 days. Erythrocytic cycle, the merozoites released invade the red cells. Vivax infects the young erythrocytes and malaria infects the old erythrocytes. Falciparum infects the RBCs of all ages. Merozoites are pear-shaped, 1 to 5 microns in the length. Receptors for the merozoites are on the red cells in the glycoprotein. Merozoites differentiate into the male and the female gametocytes. They develop in the RBC. They are found in the peripheral blood smears. Microgametocytes of all species are similar in the size. Macrogametocytes are larger in the size. So they are the macro, larger, micro, smaller. So this also I told you, ookinete to oocyst. So the parasites sucked up, then the ookinase, sporozoites, again sporozoites enter into the another human being. Vivax, benign tertian malaria. Malaria is the quartan malaria. Falciparum, malignant tertian malaria. So what you mean by these nomenclatures? Benign tertian malaria means benign as it is rarely fatal. But at what time it was thought that benign vivax, nowadays it is no more a benign. So vivax is as dangerous as the falciparum. So it is also more dangerous, the vivax. So earlier saying that it was benign, but no more benign, it is malignant nowadays. Tertian means as a fever on every third day. Relapses may occur in the vivax because of its dormant hypnozoites reside in the hepatocytes. Plasmodium ovale infection has periodicity and relapse similar to the vivax but is milder and can be cured. So if you are hypnozoites or the relapses are common in the two types. One is the vivax, the second one is ovale. So fortunately we are not having ovale in Indian patients, very few, but more of the vivax. And malaria causes the quartan malaria. So it has a 72-hour cycles. No exoerythrocytic stage, but relapses may occur in the quartan malaria. So this malaria causes the glomerulonephritis. Falciparum is the malignant tertian malaria, the dangerous one. Malignant as it is very severe form of the malaria. It can cause almost all the complications you know of in malaria. Tertian as fever occurs every after third day. Infected RBCs form the clusters called the rosettes. So the rosette formation. So all these infected RBCs, so they become like a rosettes. Such rosettes may block the capillaries of the vital organs, causing the hypoxia, then the renal failure, and encephalopathy, that is the cerebral malaria. So this cerebral malaria and the acute kidney injury is because of the blocking of these capillaries because of the rosettes formation, so that all the infected RBCs form the clusters. So the incubation period is about 9 to 14 days. So the rural people, they sit like this whenever they have this fever with the chills and rigors and etc. So the symptoms and the complications, you know the symptoms of the malaria. Shaking, chills, very high fever, 103, 104, 106, profuse sweating, severe headache, especially the cerebral malaria, nausea, vomiting, diarrhea, anemia, muscle pains, bloody stools, maybe malignant or hematochezia, sometimes convulsions, coma with the cerebral malaria or encephalopathy. So these are all very, very common in our patients. So in a complicated malaria, you can see all these cases. So complicated malaria is a DD for your hepatological cases. It is a DD for your nephrological cases, and it is a DD for your neurological cases, and also for your gastrointestinal causes. So almost all major systems in our internal medicine, you will have the complications of the malarial patients. So the central, you will have the headache, fever, fatigue, pain, backache, chills, sweating, dry cough, splenomegaly. So tropical splenomegaly is a very, very common in a chronic malarial patients. Okay, nausea and vomitings are very common in malarial fever. See here the impaired consciousness, unconsciousness, then leads to the coma also, convulsions, deep breathing, acidotic breathing, the metabolic acidosis and ARDS, etc. See the picture here, X-ray, the typical picture of your ARDS, and then the generalized weakness is the prostration. So these are all very common with the complicated malarias. See circulatory collapse of the shock. So because of this rosette formation, because of your blocking of your capillaries, hypoxia. Okay. So acute kidney injury is very common in complicated malaria. Abnormal bleeding, your dick, so elevated your PT, APTT, and then the jaundice because of the hemolysis. So this is the cold stage, hot stage, and the sweating. So you have the shivering, the fever in the hot stage, in the cold stage, the shivering, and the sweating stage. So these three are very, very common in our malarial population. So these stages are cold stage. The febrile episode starts with the shaking, the chills. This lasts for about 15 minutes to the 1 hour. So that is the cold stage. So chills. Hot stage. Cold stage is followed by the high grade fever, even reaching above the 106 degrees Fahrenheit, lasts for about 2 to 6 hours. So that is the hot stage. Sweating stage, followed by profuse sweating, and the fever gradually subsides over 2 to 4 hours. So this is a very common cycle in our malaria, acute malaria, or classical malaria, the clinical malaria. So cold stage about 1 hour, 15 minutes to the 1 hour, some chills, and then the hot stage, that is the high fever, about 2 to 6 hours, and then the sweating stage after 2 to 4 hours. So not only this fever and the chills and the sweating, so these people will also have the other symptomatology, like the headache, about 80%, myalgia, hepatomegaly, splenomegaly, nausea or the vomitings, abdominal pain and diarrhea. So these are the different presentations of the malaria. So along with your fever, so these people will have headache, myalgia, and then the nausea and vomiting. Some people may have the abdominal pain and diarrhea. And if you examine, you will have a hepatosplenomegaly, a tender hepatosplenomegaly or mild hepatosplenomegaly is very, very common in these situations. In a chronic malarial patients, you will have a tropical splenomegaly, massive splenomegaly. So hepatomegaly and splenomegaly is the enlargement, and anemia is the decrease in the RBC count, because these merozoites, so infect a lot of number of the RBCs. So there will be the decrease in the RBC count because of the hemolysis. So the common first symptoms like fever, headache, chills and vomiting usually appear 10 to 15 days after a person is infected. So you got the incubation period. It is about 8 to 12 days. So 10 to 15 days a person is infected. If not treated promptly with effective medicines, malaria can cause severe illness and is often fatal. That is very, very important. So the take home point is, so whenever you have the doubt of any etiology, so you should also add a malaria. Otherwise, if you neglect the diagnosis of the malaria, if you don't treat the malaria properly, so it's going to be a big fatal disease. So this already I told you the stage. Chills for 15 minutes to 1 hour. It is caused due to the rupture from the host red cells escaping into the blood. So that is the reason for your cold stage. Present with the nausea, vomiting and the headache. The chills here. Hot stage may reach up to the 40 degrees centigrade or 106 degrees Fahrenheit. May last for several hours, maybe 2 to 4 hours. Starts invading the newer red cells. Sweating stage concludes the episode cycle. Cycles are frequently asynchronous. Paroxysms occur every 48 to 72 hours. So your tertian malaria or quartan malaria. Plasmodium malaria pyrexia may last for 8 hours or more, and temperature may exceed even very high temperatures will be seen with the malaria, Plasmodium malaria. So the first one is the cold stage, the second one is the hot stage, and the third one is the sweating stage. So the patient presents the combination of the following symptoms. Already told you all these symptoms: fever, chills, sweating, headache, nausea, vomiting, etc. So this is the malaria tertian, 48 hours between the fevers, vivax and the ovale, the top one. The middle one, malaria quartan, 72 hours between the fevers, that is the malaria, Plasmodium malariae. And malaria tropica, that is irregular high fever, mostly the falciparum malaria. Now a word about the severe complicated malaria. So the confusion, drowsiness with extreme weakness. So a lot of the people in our emergency department, so we'll see the fever with the confusion, drowsiness, extreme weakness. So it could be a complicated malaria. In addition, alteration in the level of the consciousness ranging from simple drowsiness to the deep comatose, cerebral malaria, unarousable coma not attributed to any other cause in a patient with falciparum malaria. Okay, deeply comatose, there is no history of any injury, etc. There is no history suggestive of the CVA. There is no history suggestive of either hyperglycemia or hypoglycemia. So the DKA or the severe hypoglycemia, etc. So there is no history of any poisonings. There is no history of any drug toxicity. So finally you should also think of cerebral malaria in that patient. Say respiratory distress. So your metabolic acidosis, your bicarbonate, your pH. Here the pH will be less than the 7, sometimes 6.8, 6.9, etc. And bicarbs may be less than the 15 or 10 or also. And multiple generalized convulsions. 2 or more episodes within a 24-hour period. Shock, circulatory collapse, septicemia, maybe shock, maybe compensated shock or decompensated shock. Okay. So you will have a very wide, narrow pulse pressure. The blood pressure will be less than the 80, systolic will be less than the 80. So these are all very important in the shock. Pulmonary edema, abnormal bleeding, your dick, jaundice, hemoglobinuria, so that is your black water fever. AKI presenting as oliguria or anuria, severe anemia, hemoglobin less than 5 grams, hematocrit less than 15%, high fever, hypoglycemia. So malaria, usually the people will have hypoglycemia. So defined as the detection of Plasmodium falciparum in the peripheral blood. So always think of complicated malaria. So get the peripheral smear done, get the QBC done, or your rapid detection of your malarial antigens. So this saves the life very well. So still you are in a doubt while seeing these cases. So better to give artesunate injections. Okay, at least 60 milligrams or 120 milligrams of the stat, and then the 60 milligrams every 12th hourly. So other complications of the malaria, not only the cerebral malaria, severe anemia, jaundice, renal failure, pulmonary edema, hypoglycemia, bleeding disorders, hyperpyrexia, hyperparasitemia, complicating or associated infections, vomiting of the oral drugs, impaired consciousness, and extreme weakness. So you can remember the word as the chaplain. So C stands for the cerebral malaria or the POMA. H is hypoglycemia. A anemia. P pulmonary edema. L lactic acidosis or metabolic acidosis. And I infections. Most of these people will have the secondary infections. And N is the acute kidney injury or necrosis of the renal tubules or acute tubular necrosis. See the cerebral malaria, the first one may begin slowly or suddenly. Outcome, high fatality rate, 20%. So mostly it depends on the place to place. So with successful treatment, complete recovery is the possible. Permanent disablement rarely occurs. In second, middle one is the severe anemia, inevitable consequence of the severe infection. May be fatal unless a blood transfusion is given. Okay, so RBC transfusion is very, very needed here to tackle the severe anemia caused by the malaria, complicated malaria. Renal failure. See output and respect the output. So these people will have 200 ml, 300 ml or less than 150 ml. So there is a oliguria, anuria is very common here. Cautious rehydration is effective in the most cases. But in the rehydration, in the presence of the AKI, so may precipitate your pulmonary edema also. So that you have to analyze it. And maybe the dialysis also may be needed. Hemodialysis provided the systolic blood pressure is good. Otherwise the peritoneal dialysis, and it's a bad prognosis. Very, very bad prognosis. And others, the hepatic dysfunction, hypoglycemia, algid malaria, that is shock malaria, pulmonary edema, fluid and electrolyte imbalance, vomitings and diarrhea. Secondary bacterial infections are very common in our Indian patients. So bleeding and clotting disorders, your dick, and hemoglobinuria, that is your black water fever. So what are the possible consequences of the malarial patients? So if the mild symptoms, so you can treat it as the OPD basis. With the severe malaria, the patient is conscious and coherent, etc. So even in inpatient treatment, whether in the ward or in your single rooms, when it is very complicated malaria, so one should be admitted in the ICUs and left untreated. So finally, mortuary death is also very possible in these cases. So even though we have the 4 or 5 types of the Plasmodium species, we are very much interested on the malaria caused by the vivax and the falciparum. See here the vivax morbidity and the falciparum mortality. Okay, so that is the old slide. New slide is vivax also mortality, falciparum also mortality. So don't underestimate the importance of the vivax also. So no more a morbidity, but also it causes a lot of mortality in our Indian patients. Here the species vivax around 50% of the cases in India, whereas in Africa only 1 or 2%. 98% they are the falciparum in Africa. So among the vivax, most of the cases are in the Southeast Asia, and India has nearly 60 to 80% of the vivax cases all over the world. So our cases, about 50% of the cases are the vivax. They are the liver phase, the dormant phase is there. So that is the reason we have to treat the relapse also. And it infects the young RBCs, less severe than the falciparum, because falciparum attacks all the stages of the RBC. It's a chloroquine susceptible, but nowadays it is also chloroquine resistant. Okay, falciparum is a more severe form, more than the 50% of the cases. Infects RBCs of all ages. So heavy parasitemia and widespread chloroquine resistance with the falciparum malaria. So the incubation period in falciparum is about 12 days, where the vivax is 13 days, more or less the same. Number of the merozoites, I told you the falciparum may be the 50,000. Okay, whereas here 10,000. Red cells affected a falciparum all stages. Here the immature RBCs. Fever periodicity 24 hours. Here the vivax about the 48 hours. Severity of the first attack may be very severe in the falciparum. In the vivax, it could be the mild. Nature of the illness, falciparum is very serious. The vivax is a benign course. Mortality, yes, in falciparum most of the times. Vivax, mortality may be the negligible, but still it is yes if left untreated. Resistance is a very high level of the resistance of the falciparum, where the minimal resistance is the vivax. Hypnozoites are absent in the falciparum, they are present in the vivax. So these are the differences between your falciparum malaria and the vivax malaria. So in the falciparum, you will have the uncomplicated and then the complicated malarias. So the complicated malaria synonyms, you have the severe malaria, malignant malaria, or hospitalized malaria. See, falciparum parasites up to 35% of the RBCs, whereas the parasitization of the vivax rarely exceeds 5% of the RBCs. So less than the 5% of the RBCs with the vivax and nearly 35% of the RBCs with the falciparum. Parasitemia in the vivax ranges between 20,000 to the 50,000 RBCs per microliter, whereas in the falciparum up to 2 crores RBCs per microliter. Imagine the falciparum infectivity. Parasitemia, very high parasitemia of the falciparum when compared to the vivax. So now tell me why falciparum is dangerous. Because of the merozoites formation is the more, about the 30,000 to 50,000 merozoites. More RBCs are infected. All stages of RBCs will be infected in the falciparum. And parasitemia, degree of the parasitemia is a very, very high. Some crores. Sequestration and cytoadherence, already I told you. So adhere to the endothelium. So there will be the rosette formation and there will be the blocks in the vessels. So leads to the hypoxia and acute kidney injury, etc. And the vital organ damage like your brain or kidneys or the liver, lungs. So these are very common. So that is the reason the falciparum is very, very dangerous It can produce the fatal complications because of these things. So it can cause cerebral malaria, malarial hyperpyrexia, gastrointestinal disorders like nausea, vomiting, abdominal pain, diarrhea, algid malaria, that is a shock, whether the compensated shock or decompensated shock, black water fever that can lead to the death. So all these cases could be due to the malaria, falciparum malaria leads to the death. So the criteria for the severe falciparum malaria. So what are the criteria? Impaired consciousness. If you see the Glasgow Coma scale, so maybe less than the 11 in the adults. Prostration. Prostration means generalized weakness. Asthenia, marked asthenia. So that the person is unable to sit or stand or walk without the support. So that is the prostration. That is very common with the chronic complicated malarias. Multiple convulsions, metabolic acidosis, hypoglycemia, severe malarial anemia. So here the hemoglobin is less than 5 grams. Renal impairment. So the creatinine will be more than the 3. Jaundice. Again the bilirubin will be more than 3. Some people may be 13, 18, 20 also. Pulmonary edema is a very high common. Insignificant bleeding, shock, and hyperparasitemia. Here I will tell you one example. See, about 15 years ago, so one ophthalmology senior assistant professor came to me with fever. Okay, so at that time I examined him, and he came from the history of recent travel to the Married was there, and fever, the chills and rigors, a classical malaria. So I thought that it is because of the malaria, and then we did the peripheral smear. That was the negative, and the QBC was the negative. Okay, even then I wanted to start the antimalarial treatment, but he denied. Doctor, please give the evidence-based management. Okay, so at that time with the peripheral smear and the QBC, both were the negative. So then I started him on paracetamol, and then I have given him some antibiotic. And by the evening, and his father came to me that he is so sick. So that is because of the prostration. He is unable to sit and stand also. Then I rushed to his house. So by that time I see him, already he is in deep jaundice. Within span of morning, I seen it about the 10 a.m. So this picture is about 8 p.m. or the 9 p.m. Okay. So then we did the bilirubin. The bilirubin is 8, and urea is about 66, and the creatinine is about 2.2, and already there is some oliguria. Then I asked him to rush to a very good center, preferably Hyderabad. Then he was shifted. He is about to shift to the Hyderabad, and he developed severe hypoglycemia. The blood sugar was about 33, and we have given the 25% dextrose, etc. And then started moving to Hyderabad. So by the time morning he reached to the Nageswar Reddy, the bilirubin was 23 and complete anuria. And then he expired at about after maybe 12 to 13 hours of the hospital stay. So all these pathologies in just 2 days. Morning he came alone to my chamber, and the next day evening he expired. So severe parasitemia, severe falciparum malaria is a very common. Lot of the deaths caused by the malaria. So don't underestimate the importance of the malaria in our clinical pictures. Very common. So a lot of examples are there like that. See, I told you, nearly 80 to 90 people, they died in my hands with the severe malaria, with the complicated malaria. I think this is the #1 killer in my practice. If you see the mortality wise, very high numbers, because they come at a later time, late presentations. By the time they reach to you, already they have some jaundice, they have some oliguria, they will have some cerebral malaria, they will have some DIC, some coagulopathies. So no one can do much to this population. So some people, they may require an immediate dialysis also, so which is not possible for all the population. So some are in the shock in spite of your good rehydration therapy or the inotropics. So some people, they may not recover from the shock. So it's a very big disease as far as the mortality is concerned in our area. Unfortunately, nowadays we are not seeing much cases of the malaria. The incidence of the malaria has reduced very much in the recent days. So these are all the things, the pulmonary edema, ARDS. Again, another important reason to get the ARDS, is your complicated malaria. Already I told you the shock and the parasitic. See, this is the pernicious malaria. It's a life-threatening complication, the acute falciparum malaria. It is due to the heavy parasitization. It manifests with the cerebral malaria. It presents with hyperpyrexia, coma, and paralysis. Brain is congested. Algid malaria presents with a clammy skin, leading to the peripheral circulatory failure. The shock. So the malaria with the shock is the algid malaria. See, the malignant malaria, the falciform can affect the brain and rest of the central nervous system. Characterized by changes in the level of the consciousness, convulsions, and paralysis. See, the hyperpyrexia can lead to the coma, paralysis, and other complications. Brain appears congested. So this is your endothelial adherence and the rosette formation, sequestration of the parasites and erythrocytes. High cytokine levels could be toxic on their own. High levels of the cytokine also enhance the second process thought to be responsible for the cerebral malaria, that is the sequestration of the infected RBCs. So this is the rosetting and the clamping. Now the pathogenesis of the severe malaria. So this is because of your cytoadherence, agglutination, rosetting, and cytokine network. Cytoadherence, the infected RBCs containing the strigones, they develop the sticky knobs, which make them adhere to the venular and the capillary endothelium of the brain, lungs, kidney, liver, gut, the process known as the cytoadherence. That is the cytoadherence. This is the big pathogenesis for your severe malaria. What do you mean by the agglutination? Here the infected RBCs adhere to the other infected RBCs. That is agglutination. What is rosetting? Rosetting is infected RBCs adhere to the uninfected RBCs. That is the rosetting. So infected RBCs surrounded by the uninfected or the fresh RBCs. That is the rosetting. Cytokine network. So you have the pro-inflammatory cytokines like interleukins. So they will be activated in the malaria. So they lead to the lot of the complications. So in malignant malaria, a large number of the RBCs are destroyed. Hemoglobin from the blood corpuscles is excreted in the urine, which therefore is the dark and almost the color of the cola. How long the malaria infection can last in a man? So without the treatment, falciform will terminate in less than the 1 year. But in vivax and the ovale, because of their hypnozoids, persist as hypnozoids after the parasites have disappeared from the blood, can produce periodic relapses up to the 5 years in the vivax and the ovale. Malaria may last for 40 years, called as the recrudescence relapse. Parasites survive in the erythrocytes or the liver. So chronic complications, you have the tropical splenomegaly. So very large spleens in these people who are getting the malaria. The quartan malarial nephropathy. So that is caused by the Plasmodium malariae. But recurrent malaria, not macaria, malaria. Recrudescence, relapse, and reinfection. So recrudescence, you know that is because of the falciform infecting the RBCs. Relapse, you know that because of your vivax, that is the hypnozoids. Reinfection, the same fellow will get the reinfected with another mosquito bite. So this you should think of it in recurrent malaria. Whether it is a recrudescence, you think of falciform malaria. If it is the relapse, think of the vivax malaria. If it is the reinfection, either vivax or the falciform. So this is the very important in recurrent malaria. So earlier we used to see a lot of the recurrent malarias. So coming to the laboratory diagnosis of the malaria. Malaria is a medical emergency and requires rapid diagnosis. Very, very rapid diagnosis. So what happens to that ophthalmology professor? So today misdiagnosed, tomorrow death. So it's almost a medical emergency and requires a very rapid diagnosis. Unless you introduce the anti-malarial drugs, so the whole blood will become infected with the RBCs and then all the vital organs will be damaged. So blood film examination, microscopy is a very, very important. QBC, quantitative Buffy coat, rapid diagnosis. Now you have the strips and then the PCR, that is the molecular biology. So this is the peripheral smear. You have the both thick smear and the thin smear. Thick smear to know whether the fellow is having the malaria or not. Thin smear to know the species, whether it is the vivax or the falciparum. So gold standard method, still today, the gold standard in the diagnosis of the malaria is the peripheral smear examination. Thin smears for identifying the species of the malarial parasites, whether the vivax or the falciparum or ovale, malariae or knowlesi. Thick smears for detecting the presence of the malarial parasite. It is an art. So getting the peripheral smear and examining under the microscope is definitely a big art, and they saved a lot of the lives. So negative test doesn't rule out the infection. This is the very, very, very important carry home message. Take home message from today's talk is this one. Negative test does not rule out the infection. Still you are in a doubt. So always better to give the anti-malarials in spite of the negative tests. Repeat the test again. Repeat the test again. Okay. Expertise of the pathologist is also important. So the man behind the microscope is much more important than the result. The result in your hand is the positive or the negative. So this is not clear. It is not important. So the who is giving that report is very, very important. Man behind the microscope is very, very important. So negative test does not rule out the infection. So this is how they do the thick smear and the thin smears. So these are the different ring forms, schizones, gametocytes. Beautiful slide. Shows you the falciparum and the vivax. So please concentrate on the falciparum and the vivax only here. See the ring forms, how they are it. So you have to identify the ring forms, whether the ring of the vivax, almost the vivax is almost like your marriage ring. That is your vivax. Okay? Sirisha is saying yes. Okay? Huh? So that is the vivax. Whereas the falciparum, see the difference between the falciparum and the vivax. Schizones. So that is how the schizones. Very, very thick schizon in the vivax. Thin schizons is the falciparum. Gametocytes. Gametocytes. So sickle shape, that is in the falciparum. So that is the reason the falciparum cuts the lot of the RBCs, lot of the vessels leading to the complications. So because of the sickling shape of these gametocytes. Okay. So you please concentrate on these things, falciparum and the vivax. So the ring forms, schizones and the gametocytes. So the malarial parasites can be identified by examining under the microscope a drop of the patient's blood spread out as a blood smear on a microscope slide. Prior to the examination, the specimen is stained, most often with a Giemsa stain. Staining is also very important to give the parasites a distinctive appearance. This technique remains the gold standard for laboratory confirmation of the malaria. So these are the Schaffner's dots, oval cell, Plasmodium ovale tropozoites, QBC. Now the QBC is very, very common. It's available everywhere. That is a quantification of the Buffy coat. Has evolved as a rapid and a precise method in the diagnosis. It is the simplest and the most sensitive method for diagnosing the following diseases, not only for the malaria, and also for your trypanosomiasis, Chagas disease, filariasis, so elephantiasis, lova, and relapsing fever. So these are all the QBC can detect all these things. So malaria, filaria, and Chagas disease and relapsing fevers. Now in India, we see QBC we use for both the malaria and the filaria. QBC MP, QBC MF. MP is malarial parasite, MF is microfilaria. See the QBC here. Okay. What is this? Is it a gametocyte? Is it a ring form? Is it ring or schizones or gametocytes? Is it gametocyte or schizont or ring forms? Not schizont, not gametocyte. What is it? Ring form. Is it vivax or falciparum? Vivax. Good. See the falciparum, how it looks. It is also having the 2 dots at about 11 o'clock and 12 o'clock position. Not only the center ring, you also have the 11 o'clock and 12 o'clock positions. 2 black spots are there. Only one ring, center ring, is there in the vivax. So that is the very important. See here, only one ring. So this is the vivax, Plasmodium vivax. So this is the different pictures. The peripheral smear showing the vivax, that is our left upper, left middle, vivax shy joint, and then the vivax shy joint, etc. So this is the importance of the peripheral smear. So the peripheral smear, you can detect the vivax falciparum, the different stages also. Now moving to the antigen detection methods, the rapid test, your strip test. So various test kits are available to detect the antigens derived from the malarial parasites and provide the results in just 2 to 15 minutes. These rapid diagnosis tests are immunochromatographic tests based on the detection of the specific parasitic antigens. Tests which detect the histidine-rich protein 2, HRP2, are specific for falciparum, while those that detect the parasite lactate dehydrogenase have the ability to differentiate between the falciparum and the non-falciparum malarias. Okay, so this is a rapid diagnosis test. It's a immunochromatographic test. HRP2 is positive for your falciparum malaria, that is histidine-rich protein 2. So this is how these are your 2 strips, 2 dots is the positive. So 1 dot is negative. 1 dot means control line. Another dot is test line. Okay. So detects the malaria specific protein antigens. So now move on to the molecular diagnosis. That is your PCR. That is polymerase chain reaction. So the parasite nucleic acids are detected using these PCRs. So in PCRs we use the nucleic acids. This technique is more accurate than the microscopy, but it is very expensive. So not available in routine labs. So you need a specialized laboratory. Technical advances will likely result in the field operated PCR machines. Right now the PCR is available only in the higher centers. So now we are depending on the peripheral smear, QBC and the rapid tests. So rapid test detecting the antigens, QBC your quantitative buffy coat, and then your peripheral smear, thick smear and the thin smear. Thick smear for the detection of the malaria, thin smear for the detection of the species of the malaria, by the vivax or the proteinuria. The same thing here. The peripheral smear, some advantages and some disadvantages. Peripheral blood smear, what are the disadvantages? Expert microscopist is required. Okay. Quantitative buffy coat, easy to do, quick. A negative test can be reported within 1 minute and a positive result within the minutes. Sensitivity 50 parasites per microliter. May be useful in diagnosing the patients who have received recent antimalarials and smear is negative. And the disadvantage, a costly equipment, QBC apparatus or fluorescent microscope is required. Specimen is speciation is difficult. Accurate parasite density estimation is not possible. Antigen detection tests, rapid tests cannot test the parasite load. That is one disadvantage. And stage determination is not possible. Cannot be used for the follow-up. So these are some disadvantages of the rapid tests. And PCR, highest test sensitivity. Even at 5 parasites per microliter can be treated with the PCR. Whereas for your QBC, about 50 parasites per microliter. So the PCR is more accurate, but the thing is, you need a high lab. Skin level and the cost per test are very high. PCR apparatus is required. Now treatment aspect. So treatment must be quick. Once infected with malaria, a person's chances of survival often depend on how quickly they seek the treatment, how quickly you introduce the treatment, how quickly you give the artesunate. So that depends on the patient's survival. So the diagnosis must be quick, the treatment must be quick. So very, very important in the malaria. Otherwise, these people will end up with a lot of complications. So you have the few drugs, blood cytonticides, tissue cytonticides, and gametocyticides. What you mean by the blood zoonotics? Where they act? They act on the RBC. Tissue zoonotics, where they act? They act in the liver, hepatocyte agents. And gametocytes, so you have the male gametocytes and the female gametocytes again in the circulation. So here the blood agents, they act on the malarial parasites, which are in the various stages like the trophozoites, agents, etc. inside the RBCs. Example, chloroquine, quinine, artemisinin. So all the three drugs we use. Chloroquine we use, quinine. Earlier we used heavy doses of the quinine, but nowadays we are not using much quinine here. Artemisinin is a very, very important drug and very useful drugs right now. They are the drugs of the choice in the management of complicated malaria. So all these three will act on the different RBCs. So they are the blood zoonotics. Coming to the tissue zoonotics, they act in the hepatocytes, in the liver. So which drug will act there? Primactin. So the primactin is the drug to be treated for your vivax hypnozoites residing in the liver. Not only the vivax, sometimes the ovale also. So here the drug of the choice here is the primactin. So the primactin we have to use it about the 15 milligrams per day for about 10 to 14 days to avoid the relapses. Gametocytosis, they kills the gametocytes and hence prevents the spread of the disease. What you mean by the PCT and FCT? PCT is parasitic clearance time and FCT is fever clearance time. What you mean by parasitic clearance time? It is a time between beginning the anti-malarial treatment and the first negative blood slide. Whereas fever clearance time, it is a time taken by an anti-malarial drug to bring down the body temperature of a patient with malarial fever to normal temperature. Okay? Okay. So which one is more important for the patient? Fever clearance time. For the patient, he needs asymptomatic. So what is important for us? So parasitic clearance time is important. Otherwise, these people will have recrudescence. So if you leave some parasites active there, and then if you don't kill all the parasites there, again the people will have recrudescence or some relapses. So here this is the sign. Okay. So aims of the treatment to alleviate the symptoms. So symptoms are caused by the blood forms of the parasites. So therapy, blood zoonocidal drugs. So what are they? Your chloroquine, quinine, artemisinin, etc. Except your primactin. To prevent the relapses. Relapses are due to the hypnozoites of the vivax or the ovale. Here you use the tissue zoonocidal drug. And what is the drug? Primactin. Primactin. Okay. To prevent the spread. Spread is through the gametocytes. Okay. Gametocidal drugs. What are they? Primactin for the falciparum and chloroquine for all others. Okay. So now you got the point. Primactin has to be used in both vivax as well as the falciparum. Vivax, reason to use the primactin in vivax is tissue zoonocidal drug. So to kill the hypnozoites residing in the hepatocytes. Whereas again in the falciparum also we use the primactin as a gametocidal drugs to reduce the spread of the infection. So this is the very important. Okay. So in falciparum, primactin may be needed for just 1 day or 2 days. Whereas for the vivax, you need to kill the hypnozoites, yes, 10 to 14 days. Okay, or 7 to 14 days. So that is the difference between the therapy of your vivax and the falciparum malaria. Hare Krishna, very, very important these points. These are all clinical points. So now the coming to the WHO current and the future directions. Drug management of the malaria. Malaria endemic countries which are experiencing high levels of the resistance to currently used anti-malarial drugs as monotherapy are advised to switch over to combination therapy. So the treatment of the hypertension, combination therapy. The treatment of the diabetes, combination therapy. The treatment of the tuberculosis, combination therapy. The treatment of HIV, heart, highly effective antiretroviral therapy. So most of these are all combinational therapies. Now again in the malaria also, we need a combination therapy. No single drug. Monotherapy is not good in, in malarial population because the WHO wants that when you are using the single drug, the resistance is very, very, very high. To tackle the resistance, monotherapy is advised to switch over to the combination. So this is the flow chart approach to the evaluation and the treatment of the malaria. Sorry for the bad slide here. I am reading that the cases of the fever, microscopy or RDT, malaria was negative. Okay, microscopy is negative, RDT is a negative, or your QBC is a negative, no malaria, search for the other cause. So that is the one thing, last one. Okay. Now coming to the malaria is positive. Maybe your peripheral smear is positive, or your QBC is the positive, or your rapid test is a positive. So what to do? Then you decide whether this malaria is vivax or the falciparum. Okay. Suppose this is the falciparum, the last one. Again, you divide into falciparum, uncomplicated falciparum or severe falciparum. Okay. In uncomplicated falciparum, use the oral or IV? Oral. Oral. What is ACT? Artesunate combination therapy. For how many days? Just 3 days. Maybe your Lumerax, 80 mg. Artesunate and mefloquine. Okay. So you can give for 3 days. That is oral ACT for the 3 days. Or the single dose primaquine to attack your gametocytes. Okay. Not to have the reinfections or recrudescences. So that is the falciparum malaria. So falciparum malaria is 2 types. One is uncomplicated and complicated. In uncomplicated, you treat with the oral ACT. For how many days? 3 days. And give 1 primaquine. How many days? 1 day. So that is the management of the uncomplicated falciparum malaria oral. So then coming to the second one, the severe falciparum. Here you treat with artesunate IV. So it's available, Falcigo. Okay, artesunate 60 mg is available, 120 mg is available. So the loading dose is 120 milligrams and then the 60 milligrams after 6 hours. So that's how you have to give the, at least for the 24 hours. Then the followed by when the patient is conscious and are able to take the oral feeds, then you can switch over to the oral ACT for the 3 days and again give the single dose of the primaquine. So that is your severe falciparum malaria. Now coming to the second group, vivax. Again in the vivax, you divide into the uncomplicated vivax and the severe vivax. In uncomplicated vivax, because it is sensitive to the chloroquine, so you can use the chloroquine for 3 days. Maybe 600 milligrams base as a loading dose and then the 300 milligrams after 12th hourly, etc. So that's how you have to give the chloroquine for about 3 days. And then primaquine, how many days? 14 days to attack your hypnojoints. So that is your uncomplicated vivax. So give the chloroquine if it is sensitive for 3 days, primaquine for 14 days. Now coming to the severe vivax. Again you give the artesunate. Again 120 milligrams loading dose and 60 milligrams after 6 hours. And then the followed by the oral ACT for about 3 days and again the primaquine for 14 days. That is for your severe vivax. But here, even in India, we are seeing a lot of the chloroquine resistance. So that is the reason, even in uncomplicated or the complicated malaria, vivax, we use the ACT. So finally, in falciparum, uncomplicated falciparum, we use ACT. Complicated falciparum, we use ACT, injectable form. Complicated vivax, almost we treat like falciparum only. But the only difference is in vivax we give the primaquine for 14 days, whereas in falciparum we give for 1 day. Okay. In uncomplicated vivax, if it is sensitive to the chloroquine, we give the chloroquine followed by the primaquine for 14 days. Am I clear? So that's how we have to treat the malaria. So the treatment of the severe malaria, artesunate already give you, artemether is available. Artether is also available intramuscularly. So it was 3 shots a day, 150 milligrams OD for 3 days. Quinine, nowadays we are not using, but it's a very, very beautiful drug and very effective drug to treat the malaria. But complications are more with the quinine. So the quinine will cause deafness. Quinine will cause a lot of the blood dyscrasias, hypoglycemia, yes. Almost all the drugs will cause hypoglycemia, but that is more with the quinine. Even your chloroquine also will cause hypoglycemia. So this is the OPD management of the vivax, the Lariogo, that is a chloroquine, Lumirax, that is artemether plus lumefantrine. So we give it in the 3 days, 1 BD for 3 days. Malaria, that is your primaquine, 15 milligrams per 14 days. So that is your vivax. Ela chusta Krishna, tell me. OPD management of vivax. How we use the chloroquine? What is the dose of the chloroquine? 600 milligrams the base. Okay. The 250 milligrams tablet untadi, 4 tablets you have to give it. So tablet is 250 milligrams, the base is 150 milligrams. Followed by 2 tablets, that is 500 milligrams. Okay. So artemether and lumefantrine, you have to give 1 BD. 1 BD for 3 days. Primaquine, 15 milligrams. How many days? 14 days. 14 days. So this is the chloroquine tablets. Commonly used in the treatment of malaria caused by the vivax. Rapid schizoidal drug. No effect on the malarial parasites present in the liver cells. They won't act on the tissue hypnozoites. So this is the mode of the action. Primaquine is the tissue schizoidal drug. Exact mechanism of the action is not known, but the drug appears to interfere with the function of the plasmodial DNA. Gametocytocidal drug against the plasmodia, especially against the gametocytes of plasmodia. Falciparum, generally inactive against the heterocytic forms of the plasmodia. Okay. So this is the primaquine. It acts in the two ways. One is on the liver, vivax, 14 days. Another one is the gametocidal drugs against the falciparum malaria for just 1 day. So here the infected, FA means infected female Anopheles mosquito bites host. So liberates about 10 to 15 sporozoites. Each rush to the liver cell. Okay. In vivax, some people they take rest in the liver. That is tissue schizoids. After 3 to 52 weeks, again the relapse will occur. So to tackle this relapse, we are using this primaquine. Relapses are very common. Malarial indications. Same thing here. One thing is here. Fast. See, glucose 6-phosphate dehydrogenase G6PD deficiency. Okay. So the weekly for the 8 weeks. Weekly for 8 weeks. Vivax and ovale infection, chloroquine. Falciparum malaria. Already told you. Uncomplicated falciparum malaria. Lumirax, lumefantrine and artemether. Larinate kits like your artesunate and sulfadoxine pyrimethamine combination. And your injections, Rapither, that is alpha beta artether, that is 150 milligrams once a day IM for 3 doses, 3 injections, or straight away we can go for the Larither, that is artemether injections. So falciparum malaria, ACT, artemisinin based combination therapy. Yes. So these are the 3 artemisinin derivatives are there. Artemether, artesunate and artether. So you are very much interested in the central one, artesunate. Okay. You are 160 milligrams and 120 milligrams. This is the IV form. See the center one, artesunate. Solubility, it's a water soluble. Dosage forms, either the oral or the injectables. Route of administration, either oral or IV. Blood and tissue schizoicidal, it's the blood schizoicidal drug, not the tissue. Tissue schizoicidal is your primaquine. Action on the rosetting and cytoadherence, yes. Faster action than the others. That is the reason we are using the artenates is the drug of choice in falciparum malaria. Why not artemether and artether? Because action of the rosetting and cytoadherence is faster with the artesunate when compared to the artemether and artether. Okay. Plasma half-life 3 to 6 hours. Stability, stable in artemether and artether, whereas unstable in artesunate. So it is a potent anti-malarial activity, immediate onset and rapid reduction of the parasitemia, complete clearance in most cases within 48 hours. Clinical recovery of the patient is faster than the other anti-malarials. Efficacy is high even in the areas with the multi-drug resistant strains, especially with artesunate. Well tolerated and efficacious in both children and adults. So these are all the key benefits of your artesunate. So this is the combination Lumirax, that is artemether and lumefantrine. Artesunate is the larinate. It is a treatment of severe falciparum malaria for hospitalized patients, for ICU patients. It's a very common drug in the emergency department. So this is the injections. Each 1 ml contains 75 milligrams, 2 ml, 150. Adults who use 2 ml, that's 150 mg IM once a day for 3 days. Quinine is a very, very important drug. May interfere with the nucleic acid synthesis in the malaria parasite. Activate against all 4 forms of the malaria, even the 5 forms of the malaria, including the Plasmodium knowlesi. Rapidly acting blood schizoidal. Effective against the resistant strains also. Adverse effects: good hypoglycemia, synchronism, tinnitus, headache, nausea, and diarrhea. Okay. Chemoprophylaxis. So travelers. So mefloquine. So active against all forms of the malaria parasites, including chloroquine or multi-drug resistant strains. Ensures both suppression and cure of the infections with multi-drug resistant falciparum malaria. Blood schizoidal drug, mefloquine. Rapidly absorbed and long elimination of life of 21 days. So before traveling, during traveling, and after traveling. Before traveling, give weekly 250 milligrams for 2 weeks. During traveling, give weekly 250 milligrams. After traveling, weekly 250 milligrams for 4 weeks. So that is how you have to advise to the patients. Okay. So currently recommended by the WHO ACTs, artemether plus lumefantrine, artesunate plus amidoacquine, artesunate plus mefloquine, artesunate plus alpha-toxin pyrimethamine. These are all available here. Second line malarial agents, quinine. Can you also use the doxycycline, clindamycin. So clinda, doxy, quinine is the alternative second line of the drugs. So the more choices means more confusion. So this is a good slide. A suspected case. Okay, clinical malaria. So you are doing your microscopy or QBC or the rapid diagnosis test. It is negative. Signs consistent with the complicated malaria. Give anti-malaria treatment while further investigation referral is underway. That is the most important take-home message. Even though your microscopy and RDT are the negative, but what are all the signs? You are consistent with the complicated malaria. So please give anti-malarial treatment. While further investigations of the referral is underway, look for other causes and review later. Suppose it is the positive with the falciparum malaria or the non-falciparum like vivax. In the falciparum treatment protocol of your artesunate ACT, and then if the non-falciparum malaria, if the sensitive, you can give the chloroquine, the primacquine. So very simple, very simple. So treatment of severe falciparum is a medical emergency. Always give the parenteral antimalarials. Don't give the IM or the sub or oral. Straight away intravenous only. So these are the preferred regimes. Monitoring and the follow-up. Blood sugar should be repeated daily, twice daily in the severe infections. Within 48 to 72 hours after the start of the treatment, patients usually become afebrile and improve clinically except in the complicated cases. So this is again a very important thing. So blood smear should be repeated daily, twice daily in about severe infections. All patients should be investigated with the repeated blood film of the malarial parasites 1 month upon recovery of the malarial infection to ensure no recrudescence. So like your GDM mothers. Okay. So again after 6 weeks you have to get for the GTT. Again after 6 months, again a second OGTT. And then every year OGTT to detect the early type 2 diabetes. In the same way here, all the patients, even though they are afebrile, they discharged from the hospital. Within 1 month, you have to go for the smears to ensure that there is no recrudescence. What about the malaria pregnancy? See, the malaria in pregnancy, 2 times. One is the vivax and the falciparum malaria. Vivax, chloroquine, primaquine is contraindicated in pregnancy. So don't give the primaquine in pregnancy. You can give the chloroquine. Continue the chloroquine prophylaxis 14 days. 14 days primaquine soon after the completion of the lactation. Even in the pregnancy and the lactation also, primaquine is contraindicated. Only the chloroquine is given if it is vivax. What about the falciparum malaria? In the first trimester, don't give the ACT. Again, the first trimester ACT is contraindicated. In the second and third trimester, you can give the ACT. In the first trimester, go for the quinine and clindamycin. So this is the very important pregnancy malaria. So a lot of the people, tribal area, Rampachadavaram, Maridimil, in that area, a lot of the people are having the malaria in the pregnancy. So even the first trimester, if they give the ACT, so definitely there is a fetocidal. In the same way, the primaquine should not be given during the pregnancy or the lactation, whether it is the vivax or the falciparum. Am I clear? So you can give the chloroquine if it is the vivax, and if the falciparum, in the first trimester, give the quinine and clindamycin or the doxycycline. Again, the doxy is also contraindicated in the pregnancy. Second and third trimester, you can give the ACT. So how to prevent? Avoid the mosquito bites. Wearing long sleeves, trousers, insecticide treated bed nets, and repellent creams or the sprays. Chemoprophylaxis, already told you, the mefloquine, 250 milligrams weekly, up to 1 year. Or doxycycline, 100 milligrams daily, up to 3 months. If the mefloquine is not available, you can use the doxycycline also, 100 milligrams daily, up to 3 months. To start 1 week before the travel and continue till the 4 weeks after leaving that area. So that's how you have to give the chemoprophylaxis. So there are all the chemoprophylaxis drugs. Mefloquine doses, doxycycline. Less than 25 years, contraindicated. India, incidence and prevalence of the malaria in India. National Malaria Eradication Program started in 58, caused malaria complete disappearance, but came back in 70s, and still now prevails a major disease. Changed this national NAMP, then finally named it as NVB-DCP, that is National Vector-Borne Diseases Control Program. Now the vaccine. So final words about the vaccine. Vaccine is also there, but not popular. Children are usually most vulnerable to the malaria because they have not built up a natural immunity like some adults. In Africa, 1 child dies of malaria every 30 seconds. There are some ways to prevent the malaria, killing the infected mosquitoes, bed nets, and some medication to treat the parasite. An effective vaccine is the key step toward eradicating the disease. More studies are needed. Since the earlier trial, researchers are now conducting a larger trial of 400 children. This trial will also examine if the vaccine can protect against the multiple malaria parasites, even though it is only based on a single strain. Scientists hope that the vaccine could be combined with other vaccines and create a highly protective multi-component immunization. So World Malaria Day, 25th April, every year. Aim to raise awareness on malaria and reduce the malaria cases. Our theme is Zero Malaria Starts With Me. So you have the 2 questions. The best time to draw the blood to diagnose the malarial parasite. Before the onset of the fever, at the time of rising of the temperature, at the end of the hot stage, at the time of the sweating stage. So when the merozoites are entering into the blood, so that is the best time to get the temperature. When it appears at the time of rising of the temperature. Which of the following about the falciparum malaria is wrong? Complicated and life-threatening disease, Recurrences are very common. High parasitemia infects all stages of the RBC. One is wrong in falciparum malaria. B. Recurrences are very common with vivax due to the dormant forms hypnozoites in the liver. Good. I think next slide will be the best slide. Okay. Thank you very much for your patient hearing. If you have any doubts, I'll be very happy to clear them.